Before we start, we would like to remind everyone of the house rules to be observed during the entire webinar and to please settle down as we will begin our webinar shortly. Good morning, everyone. Good morning, everyone, and welcome to #COVID is Airborne, Understanding and Implementing the Paradigm Shift, a two-part webinar discussing the history and science of airborne virus transmission and protection against airborne COVID transmissions. I am Dr. Paulo Victor Medina, Assistant Professor at the College of Medicine, University of the Philippines, Manila, and again, I will be your moderator for the webinar. We welcome our esteemed guests and participants from different sectors and industries, science and technology, medical and allied sciences, environmental, education, government agencies, and other sectors. We are also live on Facebook and YouTube, with YouTube having automated closed captions. In late 2021, the World Health Organization officially acknowledged the overwhelming evidence suggesting that COVID-19 is transmitted through aerosols. This two-part workshop aims to detail the paradigm shift and its implications not only to medical professionals who are accustomed to the old theory of droplet transmissions, but also to the general public. The second part of the webinar today will focus on the implications of COVID-19 being airborne. It also aims to focus on equipping the medical professionals and the public with the knowledge on how to protect oneself and the measures against airborne transmissions. That being said, I again have the privilege to introduce our guest speaker. He is a professor of chemistry at the University of Colorado Boulder. and he obtained his PhD in mechanical engineering at the Massachusetts Institute of Technology in 1999. During the COVID-19 pandemic, he was one of the experts who signed an open letter to the Centers for Disease Control and Prevention and the World Health Organization, urging them to acknowledge that airborne aerosols play an important role in transmitting COVID-19. Without further ado, let us again all welcome Dr. José Luis Jiménez. Professor, thank you.
Okay. Thanks for that, that kind introduction. And without further ado, I will start with the presentation. Let me share my screen. And thanks again for everyone. This is actually has been a lot of work for a lot of people to organize it. So I'm very grateful. I'm very grateful for that. Let me get myself organized. Okay. So you should be seeing my screen now, and I put a copy of my slides in the chat. Maybe someone, since more people keep joining, maybe someone can put it in a little bit so that people who join later can see it. It seemed that last time most people liked the system, how I did it, but they said I talk very quickly and sometimes not loud enough. So I will try to talk louder. It's difficult to talk less quickly because I have a lot of material to cover. But if you have more questions on some details, you can look at the slides. The slides have links where you can go and see more information. And also I have other pieces of reference. And you can also see the talk again on YouTube and listen again to the specific areas. And we will have more than 1 hour to deal with questions after the webinar. Okay. So anyway, this is the link that I just put in for the presentation for today. The one for last week is at this link. And I'll put all of these links again in the chat at the end of the presentation. Okay. So this is the outline of what we're going to cover today, which is also reproduced at the bottom, so you can get oriented. These are the links from last week to the slides and the YouTube. So we're going to briefly remind ourselves of what do we mean, what are we protecting against with airborne transmission, and then we're going to go through 6 different types of things that we can do that will reduce transmission. Okay, so without further ado, let's go on to the reminder. So the professor who introduced me was talking about how there was overwhelming evidence, and this is just one example, a paper that we published in the Lancet about a year ago that has had a huge impact, where we summarize a lot of the evidence that the dominant transmission of this virus is airborne. That we said that at the time that the airborne route is dominant. Now, a year later, I think is probably the only important route, not the only one, but probably the only important one. And that's what we're going to be working from in order to think about the different measures. And if you disagree with this, then you have to go back and see the seminar from last week. Yeah. So what does this mean in practice? Well, in practice, this means, let me see if I can get a pen. Yes, okay. That basically we have transmission, especially in 2 situations. One is this one in close proximity. So when we are talking to someone, especially without a mask, the respiratory aerosols are very concentrated in this region in between the 2 of us, okay? Just like if this person had eaten some garlic, and then this person is smelling some garlic because it's breathing in the air that has left the infected person, right? That's transmission in close proximity, accounts for a lot of transmission. But as we saw last week, there is also this transmission in shared room air. When we have a person who is not close to the infected person, but the box, which is the room, is trapping the virus. And then over time, they can breathe enough virus and they can get infected. And these are all the super spreading events throughout the pandemic. This is the 2-slide summary of what I discussed last week in 45 minutes. Here you have a lot of links, if you want to read more about that type of thing or find out more. But I'm gonna use that information to try to explain what I think should be done, what the measures are effective against the dominant type of transmission. And the first one actually is communication. We have to explain to people what I just explained to you. and this doesn't have to be very difficult. And there is, for example, these cartoons that have been made by a friend, where you see, the aerosols are more concentrated in this region, but over time, they're going to reach people who are far away. It's just another cartoon like the one I did. You can download them from the web, from those links. And then, for example, here it's showing the dependence on time and distance. So the beginning around the person, kind of like if this person was smoking, the smoke, this invisible smoke, that is the aerosols that contain the virus, are near the person. But over time, more and more of them accumulate, and they basically fill the room. Just like if you had a smoker in the room, over time, the smoke will fill the whole room, right? And that's why one thing that people sometimes do is that they have a mask, but they only put the mask when someone else is going to come in the room or in the taxi. And by then, if that person is infected, the room or the taxi are completely full of virus, right? So for example, and that's depicted in this situation. And here is like, wait a second, I'm going to put my mask and open the door. But now this situation is pretty risky. If this person had been wearing a mask all along because they knew that people were going to come in, that would be a lot safer. So as I was saying, really, smoke is really the best analogy we have. We have discussed with the other scientists many different analogies, but really smoke is not perfect, but is the best one we have found. And it works in close proximity. You see the smoke is very concentrated, but in a room, you see how the smoke is kind of chaotic, but eventually you will smell the smoke as it mixes around. And if the room is more ventilated, there will be less smoke. The windows are open. Otherwise, there'll be more smoke, right? When I say it's not perfect, is for two reasons, especially, and it's worth explaining so that people don't get confused. What we see here are aerosols, but what we smell are not aerosols, are gases. And those gases stick to surfaces, like to the walls, and then they come back slowly. So you can come into a room and it smells like smoke because someone smoked there last week or something like that, but the aerosols are gone, So the aerosols stay much less. Those are gases, and that's something else that's not important for transmission. The other thing is that smoke from a cigarette is very strong, and we don't think the virus reaches as far. You can be on the street and sometimes you smell smoke and you don't even see who's smoking, but we don't think the virus has such a reach, okay? But it is very useful at the beginning when the person is exhaling it and is spreading as a way to understand what they do in the air, because it's very similar. Okay. So I wanted to remind also people of something I said last time. Unfortunately, the communication is very poor from most governments and from WHO. Why? Because these professions had been, a little confused because of history, because of the droplet dogma, and I mean, there is still some people that think that if we say it's in the air, people are going to panic. I don't think so. I think people are afraid and may panic if there is a lot of cases and a lot of death, not with details of transmission at this point. There is also some governments that don't want to say it clearly because they want to save face, because they don't want to say that they have said the wrong thing before. And I mean, what we always tell them is just acknowledge the science has changed. At the beginning of the pandemic, people thought other things. Now we know it goes this way, But also the other reason why many governments don't want to say it is because it is convenient. It's much easier to tell people to wash their hands. It's something they do, it's their responsibility. But if you say the virus is in the air, suddenly it's the responsibility of the government to clean the air in the schools or the government buildings, or is the responsibility of companies, and that can cost some money. So there is a lot of resistance for all of these reasons. Okay. So we're gonna then talk about barriers like plexiglass barriers or face shields and disinfection. And for the most part, I'm gonna tell you these are things we shouldn't do. These are things we did at the beginning of the pandemic because we thought we were trying to stop projectiles that were coming from one person to the other. And then if they were not hitting a person, they were hitting a surface, and then that's how we were gonna get infected. And now we know that's not important, okay? So when are these plexiglass barriers? I mean, that's how we call them here. I'm not sure how but it's basically just putting a barrier in a room. When are they useful? They're useful in a conversation, a situation like a cashier or something like that, because you see the air in this case is going like that. But if this person was closer, this person was here, they would be breathing some of that exhaled air. On the other hand, if you put a barrier, this air is going to hit the barrier and it's going to go up and down. So this person is protected from this direct, highly concentrated stream of the virus. Now, eventually, the air is going to make it this way. So they both still need to wear a mask and all that. But in this situation, like if you work as a cashier in a supermarket or in a bank or something like that, this is useful. Now, when they are not useful is when they are lateral, okay? Because basically they trap the air and they impede ventilation, right? So like in this situation, we see the air is going here and then is being trapped here and is being trapped there again. This is a simulation, but there are many studies. This is, and this has been done in many places. This is the parliament in Switzerland, and they have all these barriers, and really, this is not useful. And in fact, there is a study that was published in Science more than a year ago, where they looked at schools in the US and different things the schools had done, and then they saw which schools have more or less transmission. So the schools that had installed these barriers, they call them here desk shields, had more transmission, because about twice the transmission, because again, the trapping of the air impeded the ventilation. We see here the black line is when there is no effect. We see many things that help that we'll talk about later. For example, masks reduce transmission, reducing the time the students spend at school, also reduce transmission. Doing things outdoors also mostly reduce transmission, and we'll come back to those things. Now, what about face shields? A face shield is something that we wear. There's like our own portable plexiglass barrier. And these things are designed for hospitals, and they are based on the old droplet dogma. So the idea is that if you're a nurse in a hospital and some patient coughs on your face, and those projectiles are going to come at you and they can hit you in the eyes or in the nostrils, that situation can be very dangerous, and you spend all day close to people who may be infected. Now, in society, when people are not coughing or doing so very, very infrequently, and when there aren't that many of those large droplets that are projectiles, when we talked last time, really what you need to protect is against aerosols, against smoke. And then these face shields don't really work. This is a simulation where someone has sneezed by a group in Japan, and these black dots are all the aerosols, and you see how the aerosols are getting here, and through there. And because it's like a smoke, at the beginning, kind of like a barrier will stop it for a second, but then it will get around and you're going to breathe them just the same. Okay. And this is a study that the CDC did on aerosols, a quantitative study, and they test different types of masks. We'll come back to that, but you see here the face shields, and this is as a function of which particle size. And here is basically face shields are 0, here basically 0, here basically 0, so no protection at all. And then as things get bigger, they protect a little bit, but only against this when they first arrive, then later they don't. So it's really not worth the money in most situations, okay? Now, there can be transmission through the eyes, right? And that sometimes people say, well, we need the face shields to limit transmission through the eyes. The question is not so much these droplets that are these projectiles, but the smoke, right? And then you need to do something else. What you really need, if you want eye protection, are goggles. So something like this, these are ones from 3M. In the US, this costs between $10 and $15, and you'll probably have them cheaper from China. But the idea is some kind of glasses that are closed, that they don't let the air easily go around your eyes, right? So they block the flow of air. That's what you want. When to use this, I would say definitely in higher risk situations. So for example, in a hospital, or people who drive a bus, or who work in a supermarket or something like that, I would recommend them. Every scientist I've talked to, with one exception, I guess, thinks that transmission through the eyes is a much smaller fraction than transmission through breathing, because there is just so much more air than we breathe goes in and out, and the size of our tissues that it's in contact with is the size of a tennis court, while the eyes are small and they are not breathing, they are not drawing air in and out, right? So really, everyone thinks most of the transmission is when we breathe. Okay. So, but anyway, for some people, we could recommend, if you're gonna invest on something, then wear goggles, don't wear a face shield. Okay. You can also people who are at risk of more complications if they are immunocompromised, or sometimes people who want to be extra cautious. Myself during this Omicron wave, when I go indoors, I do wear something like this, some goggles, and this makes me feel a little better. Is it really needed? I don't know, but yeah. Okay, what else is not worth the time? So disinfecting surfaces. Okay, we said last time, transmission through surfaces, there are 0 demonstrated cases, and the CDC has been telling us, nature has been telling us. So there is all this waste, all this theater of people spraying disinfectants here in the theater, or even here they were spraying disinfectants from drones, and in Mexico they spray people when they're gonna go into a church, or anyway, it's absurd. It's really absurd things. And because it's a waste of time, it's a waste of money, and it's pollutant, and it's toxic. And for example, these were the calls at the beginning of the pandemic. These were the calls to the lines where you call when you have a poisoning. And these poisonings really increased when the pandemic started, because people started using a lot more bleach and things like that at home. Okay, so that's something that only in the hospital and only where the COVID patients are, and maybe the door handles and the light switches, things that a lot of people touch. But otherwise, it's not. Just wash your hands. That's fine. Okay. Now, since we have such poor communication, there's a lot of this that has been done. This was the Prime Minister in the UK was disinfecting the chair a month ago as he was gonna get, I guess, the booster of his vaccine or something. And it's like, this makes no sense. It's like he's gonna sit, the virus is not gonna come through his pants or something like that. This is just, but this was on TV. Oh, and I was saying here in Mexico they were spraying disinfectants, and this can be toxic, and this does nothing. This is totally useless. But it costs money, it costs time, and then gives people a false sense of security. And there's some more communication. These are some cartoons that we have made and that you are welcome to use about these things that we shouldn't be doing, and this makes it very clear. The virus is in the air, and these people are just wasting their time. Okay, so that was number 3. So number 4 is going to be things we do and places we go. What can we do in that department? Okay. So as we saw last time, the most effective thing is outdoors, because you have dilution, because the exhaler rises and doesn't hit the ceiling and come back, it keeps rising. Or there's always much more wind, 10, 20 times more wind outdoors, even if it doesn't feel like there is any wind, there's always much more air motion. You can just experiment with a match than in most places indoors. Okay, so this was in 1910 in New York. They did the schools outdoors in the winter, and the winters in New York are really cold. If you've been there, it's really painful. But yet it worked well. This was from an article, and about that thing in saying children that were too tired to play are beginning to show some interest in life. This was because of tuberculosis at the time, and they reduced really transmission a lot, and the kids were more attentive and they did better in the school. Now we find a lot of resistance depending where you are. In Canada, they say it's too cold. In Spain, it's too hot in the summer, too cold in the winter. A lot can be done if you try. If you set up some shadow, and you cannot do it every day or whatever, but if you put some effort, you can do a lot of activities outdoors. Not all of them, not all the time, not for everything, but a lot can be done, and it is worth the effort. But we're not used to it anymore, so that's something to work on. Now, if we are going to go indoors, we need to do many things. Okay, and one of the ways this has been represented is with this, what they call the Swiss cheese model. So the Swiss cheese is this cheese that has holes, and the idea is that you have, the virus is coming, and then maybe here is going to make it through this hole, and then it's going to make it through this hole and to this hole, but here there is no hole, so this barrier is going to stop it. Okay, so we have many things that we can do. None of them work very well, but the sum does work pretty well. Okay, so because sometimes people think, oh, I'm gonna be indoors, I'm gonna be working indoors all day, but I'm wearing a mask and then I'm safe. No. The mask reduces the chance of infection, but you need to do more things. Okay. And these are some posters that we did that say what to avoid. It's similar to the Japanese three C's, but has more details. So you want to avoid places where there is a lot of people indoors, where there is low ventilation, when people are close a long time, there is no masks, or when people are talking loudly. Those are all the things that don't help. Okay. Anyway, I'll leave that for later. But now, one practical example. So this is the case of the Skagit choir that we wrote a paper on, and we have a model, and I showed you last week that the model works not just for this case, but for many others to predict how many people got infected. Okay. So this is now the attack rate. So this is how many people got infected. In this case, it was like 80-something%. And this is the real case, 80-some% got infected. Now, in these 4 situations, we're gonna do only one thing, okay? We're only gonna do one thing to try to reduce infection. In this one, we're gonna increase ventilation. Here, we're gonna add a filter. Here, we're gonna put surgical masks. And here, we're gonna make the rehearsal half the duration. We see all of them help, all of them reduce the transmission from 80-some%, but only to 50%, right? So this is still a big super spreading event. Now let's say that we do all 4 things: ventilation, a filter, less time, and surgical masks. And here, sorry. So then that now when we have many layers, now instead of 80%, we are at 8%. Okay, so that's much better. And here we have, if we were to move the event outdoors, I mean, the calculation is hard to do, but in that case, maybe none, maybe 1 or 2 infected, so you will have much less cases. So this is the idea. You need to, it's not just a mask or not just ventilation. You need to do many things because neither of them is going to be perfect. Okay, and this is the cheese. Okay. Now, about the most effective measure is not talking. Okay. Why? Because we emit 10 times more aerosols and more virus when we talk, and about 50 times more when we shout or when we sing. And I'll show you some data later. Okay. So what this is showing is, as a function of the decibels, how loudly we're talking, the probability of transmission depending on ventilation. So this is at low ventilation. So you see, if you talk less loud, the probability is much lower. You talk more loudly, probability is much higher. If you don't talk, then the probability is really very small. We have a lot of outbreaks in choirs, dozens and dozens. And as far as I know, not one outbreak in a library or in a movie theater where people don't talk. Okay, so something that can be very effective, like this sign is in Spanish, this is from Mexico City, is to have signs, for example, in public transportation, telling people to not talk. Of course, you cannot. I have a colleague that said we should ask everybody in the world to be silent for a month, and then COVID will go away. And I think he's right. COVID will go away, but you could never convince people to be silent for a month. There's too many things we have to do. But in certain circumstances, for example, in public transportation or in some situations, it can be done. You can tell people, instead of talking on the phone, why don't you text on your phone or something like that? And it is a very effective measure. Okay. Now, in terms of looking, how much, if I shorten the duration, wear a mask, how risky are my activities? So as I said, is like, there is more risk of transmission if there is louder vocalization and exercise here. If you spend more time, if there is less mask or the masks are less good, if the space is smaller because the air is trapped into a smaller volume, so you're going to breathe more of it, or if ventilation is poor. And we published a paper where we quantify, if we say if there is a person that's infected where you are, or with, I guess this is for a high prevalence of infection of Omicron, and if you meet with different people, then this is your chance of infected. And if you are outdoor and there is good ventilation and it's a short time and you're wearing a mask and it's silent, basically your chance of infection is 0, right? On the other hand, if you are with a lot of people and it's poorly ventilated and you are kind of shouting or singing or it's a gym or something like that, then your chance of infection is 10-20%. So this changes enormously depending on these things. And we know what's risky: restaurants, bars, gyms, schools, places that are poorly ventilated where people talk a lot. That's where a lot of the risk is. If you want to see the numbers that we use in those calculations, or you want to do the calculations for other cases, this is online and it's free, it's available. You can make a copy at this link. And Now, it's a little, what I have found is this works for people who have a quantitative background. So for engineers or scientists or science teachers or something, this work well. For my mom or someone who doesn't do this kind of things, it's really confusing. You know? So work with someone, try to find someone, if you want to do this, that has, you know, is used to quantitative things, and it can be very useful, okay? Especially for the trends. Okay. So next thing we're going to talk about are masks. Okay. So before we talk about masks, I need to say a couple of things again. So what are the masks? A mask is a filter. What are we trying to filter? You know, there is a lot of things that you see in social media and even on the press that are completely wrong about masks, completely wrong. And people say, oh, masks don't work, and they don't know what they're talking about, okay? For several reasons, and this is one of them. I showed this last week. But this is not how the aerosols really come out. You know, this is, the virus has a diameter of about 0.1 microns, right? So this droplet, this water droplet that has the aerosol, let's say this would be something like 0.2 microns or something like that. That's not what happens. They come mostly in larger droplets with mucin and respiratory fluid and saliva, and not just with water. And this error appeared on a prominent medical journal. You know, so it's more like this. You know, you have a droplet that maybe, you know, maybe this is, I don't know, this diameter maybe 2 microns or something like that. And then it has a few virus. Most of the droplet is something else. It's mucin and sodium chloride, something like that. It has a few virus. And it's this much bigger droplet that you're trying to filter with the mask. And this bigger thing is much clumsier. Okay. Now, where is the virus? Because we know that there is smaller aerosols, there is bigger aerosols, and then there is the large droplets that are like projectiles. So there is people who have been researching this for other diseases for a long time and for COVID for a couple of years. So these are some of our colleagues from the group of Don Milton and Kristen Coleman from Singapore and the University of Maryland. So they have this machine, which is basically sucking the air, and they take people as soon as possible as they think they have COVID, or even people who may have COVID, but they don't have symptoms yet. And they talk here, you know, so they will talk or they sing, and then the air goes there and they collect. So here the cone collects the very large droplets, and then there is an impactor to collect the coarser aerosols, and somewhere else it collects the fine aerosols, and then they do virology, they do PCR, and they try to see if they can cultivate the virus. So what do they see when they do it with people with COVID? Is that basically, I mean, it's a little complicated, but 85% of the virus is in the fine aerosols, meaning fine means less than 5 microns, okay? Much bigger than the virus, you know, 50 times larger than the virus, but in diameter, but still much smaller than the large droplets that are several hundred microns. And even the coarser aerosols that between 5 and 100 are only 15%. Okay, and you know there are details here. This is more the case when talking or singing, you know, which is when we have more transmission. Okay, so really we have to filter aerosols that are, you know, we have to think a few microns is what we're trying to filter. Okay, because all of the filtration efficiencies and different things depend on the size, and knowing that size more or less is very useful. Okay. Now, filters are not colanders or sieves. A lot of times people think, okay, my mask or my filter has a hole, and the virus is much smaller than the hole, so it's going to go through. First, it's going on a bigger aerosol, but then it's not a sieve. You know, this is microscopic physics that is not intuitive. It's not, we're not trying to do this. I mean, this could happen, but it's not generally what we're trying to do. There is things like impaction or interception or diffusion or electrostatic attraction, which is why N95s work so well. And here you have two very good links to talk about that. Okay. So, you know, so when people talk, it's like, oh, the holes, then you know they don't know what they're talking about. Okay. Now, one thing is going to be the filtration efficiency. If the air is going through that cloth of the mask, what's the filtration efficiency? The other one is going to be the gaps. You know, through gaps that are very small, 1% or 2% of the area of the mask, you know, 50% of the air is going to go without filtering, right? So holes that are very small, like a lot of people have in the nose or on the sides with surgical masks, half of the air is going to go through there. So this is really the two problems, filtration and fit, okay? And this is a video from a colleague that you can see there on YouTube. And they put masks on a mannequin that was exhaling some smoke. And here it was, going through the gaps. Here it was a KN95, but they didn't fit it, and it was also going through the gaps. And this was a cloth mask, but it was a good one that was big, and it was closing all the gaps, and they had much less leaks. You couldn't see them, right? Now, there is some videos that you will see that the anti-maskers send around, and they say, oh, look, I'm vaping, so I take air from vaping, and now I exhale through the mask, and there is all this aerosol that seems to make it through the mask, and they say it doesn't work, the aerosol is traversing the mask. This is an error, okay? Vaping is a vapor, which is a gas inside of you because you're warm. When it comes out, very quickly mixes with cold air, and it forms a vapor. It goes from a vapor to an aerosol. It condenses. Just like in a cold day, you exhale and the water condenses, right? And you see. So this is an error. It's repeated a lot, but again, these people don't know what they're talking about. Okay. Now, what are the masks that work? Okay, so we want the mask to be a good filter, to be breathable, not oppose a lot of resistance. Sometimes you buy some of the cloth masks and it's really hard to breathe through them. So again, a lot of the air is going to go through the gaps, and it has to be a good fit without gaps. So the best are the N95, which are, this is one example, there are many models, and by definition, they always have these straps behind your back. Okay, these are the ones that work the best, and there are different models. You have to find one that fits well for you. Then you have the ER loop ones, which are like the KF94 from Korea, KN95 from China. These ones always leak more than these ones that have the straps behind the back. So they are less preferable, but if it's all you have, is the next best thing. The other thing to be aware for the KN95, the Chinese ones, there is a lot of fakes. Okay, so you have to be careful and try to avoid those fakes. Okay, and I have some links. I forgot to put it here, but I'll do it at the end. Now, surgical masks, it depends, but they are mediocre because they tend to have a lot of gaps on the sides and around the nose. And also, some of them in the US, the regulations say they have to be good filters. So if the air that goes through it is filtered well. In Europe, it doesn't have to be a filter. It's just to protect you if you are doing surgery and the blood splashes or something like that. So then they're even worse. Okay. Anyway, there is a study that the study I was showing earlier from the CDC, and you see the N95s, when they're well sealed against your face, basically they remove all the aerosols. The face shields remove almost nothing. And this other procedure mask is a surgical mask. These are different cloth masks. As the particles get bigger, there is a trend, they're easier to filter, but as I said, a lot of the virus is here. So you can wear a surgical mask and filter 50%, or you can wear an N95 and filter a much larger number, and that's much preferable. Okay. Now, if you don't have access to N95 or KN95, there is something you can do with surgical masks that improves them a lot, which is to close the gaps. Okay. And these are these braces. Okay. So you see, is this basically this thing that you put here, and it closes the gaps there. You see it maybe better here, and it closes the gap here on the side. Okay. And there is these people sell them in the US. I think they cost $10, but they also give you a template that you can make yourself with a piece of rubber. Okay, so now this is especially good if you have a surgical mask that's a good filter. If it's not a good filter, it's not so good. Okay? Now, the last type of mask, and generally the best, is what we call elastomeric mask. Okay? The problem with the N95s is that it's a good filter and it's very breathable, but now you're asking a material that you have chosen because it's a good filter and it's breathable, that it should also seal against your face, and that it doesn't do as well. Okay? So the elastomeric mask is you take an N95 filter, but then you put it in a plastic support, and you see here how this person is pushing on this basically bead of silicone, which is over 1 centimeter thick, and this will push against your face, and really you can talk, you can move, and you don't have any leaks. This is one particular model. This is the one I use, but there are many other models, and this existed before COVID. It's just there is some new development. So and these are cheaper over the long term for hospitals because replacing the filters is less expensive than keep buying N95s. Okay. Now, when everybody uses the mask, then you get the square of the benefit, because let's say 10% of the virus escapes, but now only 10% of this virus that has escaped is breathed in by the other person. That is now 1%. Okay, so there is this study in PNAS where they did different combinations and they illustrate this effect that you get the square, but then everybody has to wear it. If you are the only one, then you only get the linear effect. Okay, and there are other studies in the real world. This one came recently, where they were doing in California and seeing, people who were wearing a cloth mask had half the chance of transmission, surgical mask 66%, respirators 83%. Now remember, you have to do this square, 1 minus this square, sorry, the pointer is, I'm not doing very well, but the difference is actually quite big, so a respirator is 4 times better if everyone wears it, and then 95 than a surgical mask. Okay? This is another study I'll skip in the interest of time. So my summary is this something that some people I follow on Twitter said recently. So he's an infectious disease doctor at Harvard, and he was saying, frankly, cloth masks should not be allowed in high-risk settings. We should use N95. And this person is the former head of the CDC with Obama, and again, he's saying we should use N95. So I think it's, now the problem is the cost, but we shouldn't lie and tell people that surgical masks are okay because N95 are expensive. We should tell people the truth. N95 is the best. If you cannot afford it, whatever, then you can ask Tracy if your employer will buy it, or do the best you can with what you have access to, right? But we should tell the truth about what's the best. Okay. One other thing is these respirators, they need to seal against your face. They need to put pressure on the face, so they don't seal on top of a beard, okay? So the CDC has all these examples of mustaches and beards that work and don't work with typical respirators. Okay? Now, there is some people that will say in medicine, so these are not necessarily anti-maskers, but some people say, we don't know, or people with a medical training is not, that say masks don't work because randomized controlled trials haven't shown it. And these are these type of real world studies that are invaluable for vaccines or for drugs or whatever, for things that they are too complicated. There is no other way to learn if they work than to do one of these random trials, right? But remember what we said last time, that there is, when the virus is outside of the body, we can use physics. And in the physical world, we can do lots of other things. And there is many, this physics is how we got people in the moon, or how parachutes work, or airplanes, or the cell phone you have. And really, we have to trust people who know about these things in things like masks or ventilation, and not rely on tools from medicine that are really for other types of problems. Okay, so the next thing I'm going to talk about is removing the virus from the air. And how can we do this? Okay, the virus is in the air. The worst thing we can do is be in a closed room where the air is trapped and the virus is trapped. Much better is to open 2 windows if we can. And then the red is the virus, the black is CO2. So then now we have ventilation, and then the concentrations are much lower. Another thing that we can do is to keep the air, but remove the virus. This is filtration. The same that the mask is a filter we wear, we can have a machine in the room that's a filter, and you see how here the virus is getting trapped and the air is coming out, and the air doesn't have virus. Okay, so this also works, and it can be done in a few ways. The last one we can do is disinfection, and this starts to be more problematic. That means we keep the air, but we kill the virus. So we're still going to breathe that virus, but we hope we have killed it, right? And this is a lot more problematic. There is ultraviolet light, which is the one that's shown here, that does work. There's many other types that some don't work, and most of them are dangerous. Okay. Now I'll skip this. I mean, we know that ventilation works. This is a study for tuberculosis, but I see that I'm going short of time. A question I always get, and I got last time here in the Philippines, is about air conditioning. Okay. So now, if you have an air conditioner that looks like this, so a unit in a window, or that looks like this, one of these mini split units, this is not ventilation. This is just cooling. This is cooling the air, but it's not ventilating, okay? So this is like if you have a fan indoors, this is not really doing what you want, okay? Sometimes you can put a filter, but most of the time they don't have a filter. Now, you can have also ventilation in a building, and there is, openings in the wall, and air comes in and out. In that case, there is always a filter, and we should make that filter as good as possible. In the US, as good as possible normally means MERV 13. In other places, they may have different names. And some of these systems allow you to introduce outside air, and then if so, you should increase it as much as possible during the pandemic period so that the virus that maybe there is goes outside. Okay. The next thing we'll talk about are filters. Okay, so filter is like a mask, and this is the efficiency versus size. The virus is here, but as we said, really the virus and the filters are very efficient at the size of the virus, but it's not going into the air alone. It's really in this other range where most of the viruses are. Okay? And really, then you see, for example, here the MERV-13 is a lot better than the MERV-8, which is a lot cheaper. These are now the HEPA filters, the yellow line, which is basically 100% at all sizes, but it's more expensive and you cannot put it in all the systems, right? But they work. There is no question about it. Okay? Now this is a HEPA filter. It works. It's just expensive, and then this is a cheaper thing that you can build, and is a lot cheaper. And here in the US, people are building. They call them Corsi-Rosenthal boxes from the two scientists that have pioneered them. And the idea is you use a fan, and then you use blower through filters. And the thing is that when you look at here at the dollars per amount of clean air, is 8 times cheaper. Is 8 times cheaper than the other filters. Am I looking at the right one? I'm not understanding the plots. Oh yeah, no. Okay, sorry. Yeah, I was getting confused. These are the HEPA filters, and the HEPA filters are 8 times more expensive. These are the Corsi-Rosenthal boxes, different models, and they're a lot cheaper. So I know Joshua Agar there at the University of the Philippines is exploring how to do this. People in different countries are exploring it. Unfortunately, these supplies, like to do the one in the picture, are more common in the US and less so in other countries. But there are ways to do this, and this is very effective. We should have the Army doing it in all the countries. Now there is information on the web, and here you have different links for characteristics of commercial filters. And this is too small to see, but you can go into the links, and basically this is how much they cost and how much cleaner they give you. And you see here, this one doesn't cost a lot, and it gives you a certain amount of cleaner, but you can also buy this one that costs 4 or 5 times more, gives you the same cleaner, and on top of it, the color is red, tells us it's noisier. So you really have to shop around. As I'll say later, there is all kinds of things being sold with the pandemic that, I've seen some of these filters that normally cost a couple of $100. I've seen people selling them for $2,000, and they are not any better. It's just people taking advantage of people's fear. Yeah. Now, where does the clean air go? I don't know if this video will play. Okay, this was a video, but it's not playing. But basically, the idea is that sometimes people say, well, if I put a filter or if I have the windows open, what's happening? You can light a match and see where the air goes. So you have these smoke generation machines, and these are some parents in a school in Australia, and they were basically taking a video and putting smoke and seeing what happened with the smoke, depending what they open, and depending here they have one of those filters. And they were seeing, is the smoke going in the filter? Ideally, you want the filter in the middle of the room, but it's not always possible, but this can be studied, and it's not hard. Okay? One other question people ask all the time, what happens if I'm with someone at home that has COVID? And the idea is that whichever air that person is exhaling, you don't want to inhale. So in this particular case, the sick person is here in this room. Oops. Here, okay, the sick person is here. And then what we want, we open the window, and then we open this other window. So the idea is that the air is going to be ventilated, and it's not going to go to the rest of the house. And here, for example, if there is a door towards the rest of the house, then we put a towel or we do whatever so that we close that flow of air. And then if we have a filter, we put it here in the room. And if the person has to go out or something, then we all wear masks during that period. So that's how you apply it to that particular situation. Now, ultraviolet light works, and this was shown for measles 60 or 80 years ago. So it works. It's just more expensive and complex. These are some of the data for measles. It works just as well for COVID, but it's more expensive and complex, and it has more risk if it doesn't do well. So it can be useful, I would say, for a prison or for a hospital. I wouldn't do it in the schools, and certainly not at home. Okay. Now, I'll leave this for reference. Just I'm doing a short of time. Now, there is a lot of things that are being solved with ions, plasmas, photocatalysis, ozonizers, foggers that put hypochlorous acid or different things. The idea is that all of these things are variations of the same idea. Is this disinfection? You put chemicals in the air that are going to somehow encounter the virus and are going to react with the molecules of the virus, which are lipids, proteins, and nucleic acids, and they're going to kill the virus. They're going to deactivate it. Okay. Some work for that, some don't. Okay. But there is two problems. If we are breathing that air, we are made of the same thing as the virus, lipids, proteins, nucleic acids. So this is going to do damage to us. And on top of that, they're going to react with indoor contaminants. And they can produce more dangerous contaminants. So even though they're being sold a lot, this is dangerous. Okay. And this is one example where we see, this is the production of contaminants when things go up. I'm going to skip it again for time. Now let's skip this one about the humidity. Okay, so the last thing I was going to say was about carbon dioxide, measuring carbon dioxide, which is something very useful. Okay. What's the idea? The idea is we exhale these aerosols, so whoever is infected may exhale those aerosols that we say are small, like 5 microns, and they follow the air, just like the CO2 that we exhale. The food that we eat, we turn into CO2 and we exhale it, and it accumulates indoors. Okay, so they accumulate in a similar way, not exactly the same, but it's the best thing we have that we can measure easily. Okay? And here there are details and links, but I'll skip that. Breathing air with a lot of CO2 is not only bad to get infected, we also get dumber. This is a study from Harvard where they see that when people are trying to solve a problem, at 500 ppm, they solve it better. When they are at 1500 ppm, which is very common indoors, they are a quarter as smart. So we shouldn't do that in schools or in offices, yet we do it all the time. Okay? So a CO2 meter, and this is one. This is the best one, although it's expensive. It's called the Aranet. I don't have anything to do with them or any other company. Anyway, so this is what you measure outdoors. It's like 400, and then in a place that's poorly ventilated, in this case, my car with my wife and my son, you get to 4,000, and that means 10% of the air you're breathing for the second time, and that's the dangerous situation. Now we open the windows, something, and then it goes down a lot. So and they measure very quickly every minute. This is more expensive. There is this link there where some colleagues have tested many. And basically what you want is these ones that are NDIR, non-dispersive infrared. Most of those work. There are cheaper ones that cost $20, but then those you put alcohol in your hands and the CO2 goes up because they're not really measuring CO2. So you really want the infrared ones. Now the levels, these are some schools in Spain, and I was telling you 1,500 is bad. Every school was above Spanish law and many were at a few thousand. What we recommend really is 700, and the CDC recommends 800, and there is different recommendations. It's something of that order. Okay? Now, we think that going forward, in every place where we share the air, there should be one of these in the wall, in every restaurant, in every school. This is already a law, for example, in Taiwan, in the schools, and it should be everywhere. And now in Belgium and in some places in Spain and Argentina, and it can be done and it's cheap, Okay, so what can we do with CO2? So I think I only have a couple more slides. Sorry if I'm going a little longer. So you can monitor ventilation and make sure you open your windows enough. So for example, it's very hot in the Philippines in the summer. You don't want to open the windows because you spend more air conditioning, you're hot, it's muggy. So sometimes people say, I'm going to open the windows and then close them and then open and close them. That doesn't work, because this is when you close them, the CO2, the exhale that accumulates. Now you open, goes down, but then it accumulates again. And really, you have to be opening them all the time. And what works better is to open them a little. So instead of opening them a lot, open them a little, but keep them open continuously. How much is a little? You measure CO2. And you don't need to measure CO2 every day. You need to measure CO2, a couple of days, and then you get to learn how that is, if there's wind or no wind or whatever. So you can have one of the CO2 meters, and every person doesn't need one. You can share it with 20 friends or with a school or things like that. Okay. And that's another example of the same thing. This is an airplane that someone was asking last week. So this is a trip from a colleague. And here the colleague was in the bus and the air was pretty clean, but then they went into boarding, and when they board, normally the ventilation is not on, so the CO2 went quite high. Now, then later they turned on the ventilation, and then when the plane was in the air, it was pretty good. But now they landed, and they turned off the ventilation, and the CO2 started to accumulate. Now, my colleague was in the first row, so he left very quickly. he went outdoors, and outdoors is this level, and then he went into a train, and it was like that. So when you think about a trip, you have to think about all the periods where you're sharing the air. And when you are flying, is not the most dangerous. It's often boarding and that kind of thing. Okay, so then unfortunately, the theory is good, but in the real world, we have a lot of problems besides technical problems, okay? So there is lies, fraud, and corruption. There is a lot of this. Many governments just openly lie, many companies, they want to keep responsibility on the individuals. They don't want to take responsibility, they don't want to take costs, and they want to reduce restrictions because of the economy, otherwise the economy will have problems, So there is still many governments that say that washing your hands is one of the most important things you can do. That's a lie. That they say that surgical masks are just as good as N95. That's a lie. Our ventilation meets the standard in this school. What's the standard? That's often, you can always improve it, because they say that when they don't want to put HEPA filters. A HEPA filter is always going to make it better, Or they say the HEPA filters don't work, or they move the virus around, or, these are all lies, but they are repeated worldwide. Now, there are many companies, like I mentioned earlier, that are selling useless or dangerous products, like these ionizers, ozonizers, that are selling like hotcakes. And they often tell you, oh, the HEPA filters is the old thing, or my thing is the new thing, and NASA likes it, and don't pay attention. Or these CO2 meters that are not NDIR, even some of them say they are NDIR, even though they aren't, so it's fraud. And also these fake KN95 masks, or a lot of cloth masks that are very poor in performance. And there is a lot of corruption. I've been surprised during the pandemic, but even in places like the UK, the government was going to buy HEPA filters for the schools, and they bought from one manufacturer, and it was 10 times more expensive than the other ones, and they were not any better, and they were noisier, Or, and many similar cases, and people who are politically connected suddenly get the contract for the filters, for the CO2 meters, whatever, and suddenly they're more expensive and worse than they should be, So anyways, it's sad, but that's the world we live in. So in terms of more references, every question I've always been asked is in these frequently asked questions at this link, and there is an automatic translation, so you can translate into Tagalog or other languages. These are links for more information. Again, you can get them from the slides, and that's all I had. Sorry, I went a little long, but we still have an hour for questions, and thanks for your time and for your attention.
Thank you very much, Professor Jimenez. Maybe a bit of a breather while the team also tries to curate the questions that have been coming. Thank you very much again for that very excellent presentation and very insightful presentation. A reminder to all of our participants, the Q&A box is open. So kindly quickly browse through the Q&A box and just upvote your questions if you find that there are similar comments or questions already posted. And then what we did, the team has been trying to collapse and combine questions that are similar based on the feedback from part 1 of the webinar. So we do apologize if you feel that your questions might have been lost in the Q&A portion. If you really feel strongly about your question, just keep on putting them in a Q&A box, and we'll try to see if we can attend to those comments and questions. All right. So Professor Jimenez, are you ready for the next round of Q&A? I'll let you drink a bit of water first, sir, to help you catch your breath and be ready. All right. So with that thumbs up, let's begin the Q&A portion of the webinar. So Professor Jimenez, there's a question here. What happens when my mask gets wet when I talk so much? Can I use a surgical one under an N95? And in general, when should we double mask?
I'll start by the end. In general, we do not recommend double masking. The idea of double masking is if you have 2 masks that are not very good, like a cloth mask and a surgical mask, you can put one on top of the other, and that may close the gaps. That was why the CDC was recommending them. But it may close the gaps, it may open the gaps. And it also makes it hard to breathe. Now you have to breathe through more cloth. So then more air goes through the gap. So in hospitals, I mean, there is one exception. In a hospital, you can wear an N95 below that's well sealed against your face, and then a surgical on top. And that's used to protect your N95 from getting dirty. Like if someone is gonna cough or you're doing surgery or something, that can be useful. But otherwise, an N95 that's well fit is all you need. And then don't make things more complicated. If it gets wet, that matters for the surgical mask, or especially the N95. Then they start to work less well. So if they get very wet, then you wanna change it, after a certain period of time. And you shouldn't wash it. I mean, some people wash the N95s. That's really making them worse, because they use electrostatic charge, and that doesn't go so well with getting them wet.
Thank you very much, Professor. Another mask question, and we collapsed several comments and questions here. Since high quality masks are expensive, Professor, can we reuse these high quality masks? And if so, do you have any tips in terms of the ideal way to do this? You were mentioning do not wash the masks, so that's good. But there's a question here, can we sanitize or UV sterilize these N95 masks? And if when to replace these N95 masks, Professor, if you have an idea about them. Thank you.
Yeah, so this is, at the beginning of the pandemic, there were regulations that N95 should be worn once in a hospital and then thrown away, or worn for a day or whatever. But really, I mean, that's exaggerated. Really, the tests show that you can wear it for at least 40 hours. So you can wear it on your work week and it's fine. And even if you don't have access to more, wear it a second week, it's okay. As long as they don't get very wet, they keep working, okay? So sometimes people, rather than buy many surgical masks and be changing them all the time, get one N95 and wear that one. Now, with respect to, if you're working in a classroom or something like that, I would just say, then take it off at night, hang it somewhere, wash your hands, and just be careful. If you work in a hospital or somewhere where there could be a lot of infected people, what some people do, I mean, you can do that UV disinfection or something, but you don't need to. You can have 5 masks, one for every day of the week, and you put them in a paper bag or you hang them. And then today I take Monday's mask, then I put it back in the and I wash my hand, and tomorrow I take Tuesday mask. And from one week to the next, any virus that may have been there is dead. So that's simpler than trying to do the other things.
Thank you very much, Professor Jimenez. Not sure, so the team, can you just monitor my feed? I think my internet is not stable, but hopefully it resolves itself soon. Another mask question, Professor Jimenez, I think this is in relation to the fit. What is your comment here? If we had headbands or ear savers on KF94 or KN95 masks, will it have the same performance as an N95? Hello, sir. Was it me? Go ahead, sir.
I got disconnected for a second. Could you repeat the question?
Sorry, sir. Yes, I thought it was me. So the team, could you please monitor our connections? Sir, if we add headbands or ear savers on KF94 or KN95 masks, do they affect, I think they're asking about the fit. Will they have the same performance as an N95, sir? Would you recommend those headbands or ear savers?
On a surgical mask?
On KF94, sir, or KN95 masks.
Okay. Yeah, so to use the things that make it, they work better, right? I mean, so the problem with the KN95 is that the material is a good filter, but they tend to have gaps around the edge because they don't, I mean, ideally you will have it go on your face like this, like an N95. If it's going on your face tangentially, that tends to leak more, But if they're tighter, like with those ear savers, that's better, So if that's what you have access to, then that's better, yeah.
Okay, sir. Sorry, sir, I think this is another practical question about masks. Since the N95, K95, or KF94 masks are fitted for adults, what masks would you recommend for children or those with smaller faces?
So there are some, like for example, one of the 3M masks that has the B-Flex is one of the 3M K95s, and they sell them on big size and small size. And the small size fits well for older children, like 12, 13, 14. So that's one option. For smaller children, there is the Korean KF94. They do sell children's sizes, and my son has used those. I have a 7-year-old. They also sell elastomeric masks for children, and that's what he wears now, and it's called flow mask. So it's similar to that other one, and it, it's basically again something that seals well against the face with an N95 filter. So I would suggest something like that. There are fewer options, but there are options for children.
Thank you, sir, for that, and I hope the audience is listening and starting to make those connections. Where do we search for these things locally? And of course, hopefully the government regulators are also here tuning in so that we can also start demanding for better policy in terms of these masks and making them available. Thank you, sir. This is now a filtration question, sir. How long should the HEPA filters run inside a closed room before a gathering? And how long can it be turned off during an event to reduce the noise? So very practical question, sir.
So before a gathering, I mean, unless there was someone there before, it doesn't need to run. So the idea again is when the people are there, that the virus is going to be coming out. That's when you need the ventilation and the filtration. Sometimes, like there were some schools in Spain, and they were opening the windows for 2 hours before the children arrive, then close the windows when the children are there, and then open the windows when the children left. That was a complete waste of energy, because you were ventilating when the kids were not there, and then you were making the children breathe the virus. So the idea is you have to ventilate when the people are there.
Thank you very much for that very, very practical answer, sir. Again, for filters, sir, MERV filters are not commercially available here in the Philippines. Instead, several HEPA filters are sold in online stores with prices ranging between $2 to $100. Do you have any tips, sir? How can we separate the authentic and fake filters? Is there an immediate test we can do to access HEPA filters? You were mentioning something about alcohol and those carbon dioxide measuring devices. So would there be a similar test that can be done, sir, for HEPA filters?
Well, I mean, so first one precision. One thing is the filter itself. So when I say a MERV13, is not a box with a fan, it's just a filter itself. And those are the ones you would put in a building for air conditioning. And I'm sure there is something like that in the Philippines. It may have a different name. Now, if you're talking about a box, like a HEPA filter that has a fan and the filter inside, and how to find a good one or a bad one, there are fake ones, and then normally the fake ones are the no-name brand from China. There are some of them are okay, but some of them are not. And often you see that the quality is not very good, and they may have gaps and things like that. So I would say, if it's a brand that like Xiaomi or from China, or Honeywell or some brand like that, they can be tested, and they can be tested with these portable meters that are called condensation particle counters. But this would be, someone will have to do this in a laboratory at the university. I don't know if there are people. I mean, this equipment costs $5,000. So it's something that we have in research labs. It's not something you can do at home.
So I think the message there, sir, is we have to be collaborating with these academic institutions if they do have the capability and capacity. Yes, sir. Go ahead, sir.
One more thing is that people have been doing this, and there is people who've been doing this in the US, in Australia, and in Spain. And I put all 3 links are in the presentation. So you can see, and there are many of the filters are the same because they are either Chinese or Honeywell or whatever. So you can see how they recommend, what they recommend, and what they have tested.
Thank you for that reminder, sir. And I think going with the presentation, there are people in the Q&A box who are asking, will the slides be available and will the recordings be available for the 2 parts of the webinar series? The answer to that is a resounding yes. And so the organizers will just keep on promoting the links and typing them in the chat box or in the links shared on social media. So kindly just watch out for those. They've already been shared, but we will share them again so that the people who've been asking can benefit. Thank you very much. Sir, this one is a communication question. And maybe you can share as a scientist. I'm pretty sure you're quite used to communicating to fellow academicians and scientists. But when you talk to lay people, sir, although they are already aware of airborne transmission, people still continue to spray disinfectants, alcohol, sanitizers in the air. Is there real value for that? And do you have any tips, sir, on how that can be communicated better to people?
Yeah, I meant to say a little more about that, but spraying disinfectants in the air is dangerous. It's disinfection of the air. That is dangerous. You should never do that when people are there. And as I told you, it only matters when people are there. Otherwise it doesn't matter. Why would disinfect the air that nobody's gonna breathe? So definitely we shouldn't do that. I mean, there is a problem, and it's not science, it's sociology, right? When at the beginning of the pandemic, we were all very scared and we all were ready to do whatever they told us. And they told us, it's on the surfaces, wash your hands, disinfect everything. I was the first one who disinfected everything. Now, the problem is afterwards, for the reasons I mentioned, a lot of the governments, either they've been confused or they haven't been wanting to explain it clearly to save face or because they don't want responsibility or whatever. And we have to say it really strongly, because really what we learned at the beginning of the pandemic is really, we learned when we were really scared with fear, is really deep into our brain. It's very hard to unlearn it, and now we've heard so many things and so much contradiction and so much misinformation. So now you need to say it really clearly and really say it again and again. And I mean, that's what is my part-time job. I have on Twitter, I have this hall of shame where anytime I see someone disinfecting the air or whatever, I put it there, and from different countries and whatever. And I have another one where I see someone doing things well, I put it there too, And it's one way to try to get the word out, but but there is a need for very large campaigns, and in my mind, that is the biggest need. What we have to do is not so difficult. If people just understood that it is like a smoke, that the infected are exhaling like some smoke. And at some point I was talking early in the pandemic with someone in India, and I was trying to explain the ventilation, and we were both very confused because the houses there are very different than what I'm used to, and I've never been to India. But then I explained to them, it's like smoke. And then they were like, oh, it's like smoke. I was like, oh, okay, thank you. They never asked me again because they understood what they needed to understand.
Thank you very much for that, Professor. Again, this has been maybe just so that the team can all put the questions again in the in our Google Sheets. It's nice that you mentioned that, sir, about the campaigns. I think we should now start to really figure out how to get the message across and really say that this is how it's transmitted, and we can come together better. Thank you very much for that reminder, sir. Sir, another practical question for individual households. Since not all can afford to retrofit their homes nor buy air filters here in the Philippines, what are practical ways aside from keeping our windows open that we can do to ensure that the air we breathe at home is clean?
I mean, keep the windows a little open. Try to borrow a CO2 meter or buy one with your friends. Or, I mean, in some countries, what people are doing is they basically have like libraries, and you can check out a CO2 meter for a day and then measure a lot of things. That can be really useful. Maybe the university could do that, or someone could do that. So that you know how much to open the windows, because the problem is not opening the windows a little, which normally what you need, but when people open the windows a lot. Now, a filter, you can always try to build a filter with a fan. If you have a fan not to be hot, again, Joshua Agar was showing me some kind of filter material that you can just tape around, and you can make a filter that doesn't cost you very much because you already have the fan. Otherwise, you can wear a mask. It's difficult to do at home, but if you if you think someone could have COVID or there is a riskier situation, it's a good idea to wear a mask, especially when you are talking. You don't need to wear when you sleep or when you're working on your computer, but when you're talking, may not be a bad idea. And if for example, if you live with someone who would be at very high risk and is not very well vaccinated, then I would say that person should wear a mask and should eat separately from the others, because it's when we eat and we talk that's when it's riskier. So these are some of the things you can do.
Thank you very much for that, Professor. I think this question is again about HEPA filters. You were starting to explain this during your presentation, but felt that you didn't have the time. So maybe this is the time to be able to do so. Can HEPA filters, sir, work with COVID virus given the particle size? Some say of the virus, some say HEPA filters cannot filter the virus because they are too small.
Totally wrong. Both. I mean, and I mentioned that in the talk. HEPA filters work very well, remove all the virus from the air. Because the virus is present in much bigger aerosols that also have saliva or mucus or different things. So you're trying to filter something much bigger than the virus. And the HEPA filters filter everything. They filter almost completely everything, bigger than, smaller than the virus. And, so sometimes governments will say that, sometimes people are confused and they will say things like that. But I have a colleague at the university, they put filters in classrooms, and then they took the filters back to the lab and they analyze the filters with PCR. And they find the virus, the COVID virus, the SARS-CoV-2 virus was in the filter. That can only happen if the filter works, otherwise it will go through, right? So definitely they work, and there is a lot of disinformation. And I have some colleagues, I think I put some links to some of the threads. I have colleagues who have written long threads about all the wrong things that are said about HEPA filters or about filters.
Thank you very much for that, Professor. Maybe this is now a personal interest question in terms of these HEPA filters. Where do you place them, sir, in a room? I heard that you need to have the air flowing through them for them to be effective. So some people would place them in certain areas of a room. Would you have any advice where to place these HEPA filters, sir?
Yeah, so what you want, again, the idea is that it depends what's going on in the room, right? And who's at risk or something. So for example, my mom is 80-some years old, so I bought a HEPA filter and I told the caregiver that lives with her, the clean air from the filter that comes from the top should always go towards my mom, so that she's always breathing clean air. And in fact, she had one of the caregivers was infected, but my mom didn't get infected, maybe partially due to that, Now, if you are in a classroom and there is a lot of people, if you can, you will put it in the middle, Now, if in the middle is not possible, then you put it maybe to the side, but you don't want to put it in a corner. What can happen in a corner is you can get short circuiting, and then you're filtering the air of the corner over and over, but you're not filtering the air in the middle. Sometimes what people do is to avoid that problem, or if the room is bigger, instead of buying one very large filter, you buy 3 smaller ones, and then you put them in 3 parts of the classroom, things like that. Again, you can do the experiment. If there is a classroom and there is maybe some ventilation, you open the windows, light a match, and then you extinguish it, and you see what the smoke does. Or with a cigarette, if you can do that, or one of the smoke machines, and then see what the air is doing. And what you want is the air to go to the filter as quickly as possible.
Thank you very much for that, Professor Jimenez. A question here on wearables. Wearable air purifiers, sir. Are they effective? Like, for example, the LG Puricare necklace types that are very popular here in the Philippines, actually. Do they work, sir?
Do they have a filter, or do they have a UV light?
I'm not that familiar, sir. Would you have any comments on either?
Yeah. And then do people wear them with masks or without a mask?
No, sir. People would often have masks because they're required, but people just wear them, sir, as necklaces. Sometimes.
Yeah. So it depends on the type. There are some that have a filter, and then they are good for the person who's wearing them. But if that's the infected person, they are not good at all for everybody else if that person wears a mask, because the virus that person, because the air is filtered, that person is breathing filtered air. Now, if they use UV light, which there is some that were being made in Europe, that one I will recommend less, because the UV light is producing some chemicals that may be not good for you. And then there are others that use ionizers. Professor Agar is telling me that on the chat. Those don't work. Don't work at all. Ionizers don't work. They're a scam. And so that's a scam, basically.
Thank you very much for that, sir. A related question. Do air purifiers with the advertised UV light work? Or does UV only work for sanitizing masks? And how about those advertised as ozone air sanitizers, sir, or UV sanitizers?
So those are different. If they have UV and not ozone, um, it works very well for surfaces. In a room, it can work, but you kind of have to have it in the ceiling, and then so that the UV doesn't go to people and whatever. And they work for this virus, they work for the pathogens. They are more expensive than filters, So if normally money is a big concern. So in some place that's very dangerous, like very risky for transmission, like a prison or the emergency room, or something like that, you can invest in the UV. But in most places, ventilation and filtration are going to be cheaper and less dangerous. And then you mentioned the ozonizers, the ones that
Yes,
make
sir.
ozone. That is straight dangerous. Ozone works to disinfect surfaces if nobody's there and you have time to ventilate. Okay, but when nobody's there and you have time to ventilate, that's not relevant to this virus. This virus almost doesn't go through surfaces. This virus, we're breathing it in when we're sharing the air of a room. And ozone is a very toxic gas. It kills almost 500,000 people or more a year from outdoor pollution. And these machines that make ozone make enormous amounts of ozone. So that is very dangerous. That should be outlawed, in my opinion.
Thank you very much, Professor Jimenez. You mentioned this in your talk earlier, but maybe a bit more clarification. Sir, what defines high occupancy in assessing risk? Is there a certain percentage of usual occupancy?
Well, I mean, it depends on what you're doing, right? And how much time, and are you talking or are you quiet, or so if you are in a place that's well ventilated, like often the metro, the subways tend to be very well ventilated and people are not talking and they're wearing masks, so you can have a lot of people and they're still not very risky, because there is not a lot of virus in the air, and if there is virus, it's ventilated very quickly. On the other hand, you can have a choir or something like that, and they're putting a lot of virus in the air, and if they're not wearing a mask, even in a big church or something like that, it's still going to be dangerous. So as I said, if you want to have an idea quantitatively, I would suggest that you go to this estimator, and then you can see, the risk of different situations.
Thank you very much for that, Professor. At the risk of being, criticized, but it's good that you mentioned that in a subway or in the metro, that particular setting, you can actually do that as a low risk activity. I hope that people in our transport sector are listening, are tuning in the webinar, and maybe thinking of these ways to reduce the risk. Not just looking at saying, oh, there are so many people, it's inherently going to be risky. And I think you already shared a lot in your talk for them to start thinking about those. Thank you very much, Professor. Professor, this is a question that's very specific now to dentists. They are among the high-risk individuals for infection due to their exposure to oral procedures. Would you have any best practices for mitigating transmissions in dental offices? Can we remove the lateral barriers between dental chairs as long as we keep CO2 levels to around 1,000 parts per million?
I think the recommendations would be similar to other places. So ventilate, use a filter if you can. Something that works very well, because really where the aerosols are being produced are in the mouth of the person, when they are torturing you with those things. And, so there is something that's called localized extraction, which is basically a filter that's sucking a lot of air right from the mouth, right? And it doesn't need to be very expensive. And again, you can make it yourself. And then it sucks a lot of air from the mouth. So if you are producing any virus, it's going to this thing, to this fan, and to a filter. So that works really well. But then you also can have the windows open if you can, or have a filter in the room if that system is not catching everything. Then the dentist should wear a good N95 mask and eye protection, because there can be some splash, so some goggles. And what I do, so I've had to go to the dentist a few times during COVID. So what I had was one of these, a surgical mask, but I just put it over my nose. And I made sure that I was always breathing through the nose, so to protect myself in case someone else there was infected, as the patient. That's as much as you can do, probably.
Thank you very much for that tip, Professor. Again, going back to the first principles of the thing. Maraming salamat. Thank you, sir. Sir, here, what do you recommend for large, low-ceiling malls, shopping malls, where many Filipinos go to all the time, banks, offices, and other establishments with inherently poor ventilation? There are no windows, they're air-conditioned for the whole day. Only the entrance doors, sir, are open. And they're open a lot of times because people come in, go in and out. What can people do for their safety? Maybe it's a two-part question, sir. What can the establishments do? And then for the people, sir, what can they do?
So in that type of building, there is normally some system in the ceiling or whatever that circulates air for the whole building. So then they can do two things. They can put a better filter. There is always a filter. So the air that's recirculated that may have the virus goes through a filter. And then they can take more air from outdoors that costs money because you use more energy. For example, in a very hot day in the Philippines, if you throw the cold air from inside outdoors and you take hot, humid air, you have to spend more energy. But during the pandemic, it's worth taking that extra cost of energy and taking as much air from outdoors as possible. That's, for example, what we told our university, and that's what we did. So that's what the establishment can do. The establishment can also distribute good masks, for example, and for example, if I don't know, I would say if you are a mall and you say, okay, I'm gonna give you one N95 or something, that or a KN95, that may be an incentive for people to go shopping there, right? And they should require that people wear at least a KN95 if they're distributing them. So if someone is coming with a surgical mask, say, can you put the KN95 while you're here? Things like that, and make sure everyone wears masks. If you are the customers, I would say, go as little as possible, but and if it depends, if you happen to work there and you have to be there all day, get a good mask and eye protection, I would say, and measure the CO2. I mean, sometimes it can be surprising. There's buildings that people think, oh, my office has no ventilation, and they're very scared. And then they measure the CO2 and actually it's very low. And the building actually has good ventilation, but ventilation is very confusing. That's why the CO2 measurement is really eye-opening. And there are other places that are new and shiny and whatever, and you think, oh, this place must be very well ventilated. But then the ventilation system, this happens very often, has failed and is off. and there's no ventilation at all, but the place is very shiny, and so that's kind of with the CO2 meter, you immediately realize this, and then you go tell them and they say it's impossible, and then they check, and of course it's possible.
Thank you very much for that, Professor Jimenez. Regarding CO2 sensors, can you point us to protocols that can be adopted in our workplaces? Is it possible to just use these sensors to determine max room capacity one time rather than doing real-time monitoring for all rooms in the workplace, which would require more units?
I mean, ideally you measure all the time, but if you're going to be doing the same thing, for example, you are in a classroom and you're in the same classroom every day. My colleagues have done this, and basically, I'm always measuring CO2 at home. It's very boring. It's the same every day. It's like if you do the same thing, you see the same thing. So the only thing, if you open the windows, it's different if a day is very windy or if a day is very sunny, or so you kind of have to do it a few days. But then you learn, and then you say, okay, in a day that's not windy, I have to open my windows this much. In a day that's very windy, I can open them a little less, and so, and then you can share it, or sometimes you can have it one per school, and you can make it a project for the older students, like a science project. And you say, okay, 1 hour a day, you're going to go through all the classrooms and you're going to write down what they're doing, and then you report the data, and the students get very excited, and then you learn very quickly. They are very motivated to do these measurements, and so you can do things like that. But yeah, I mean, I recommend against sharing them or using them some kind of library or something, because they're too expensive for most people to have used one for themselves.
Thank you very much for that, Professor. In terms of dining experience, or how can we make the indoor or outdoor dining experience safer while still enjoying the experience?
Well, I'm sure there is some restaurant owner that's gonna not be very happy with my answer, but I haven't gone indoor dining since COVID. I think it's just the most dangerous situation, because people are talking and then you are indoors and there is a lot of people or whatever. I mean, if you were in a place that were very few people, maybe, you know, but that said, I've gone outdoors to restaurants many times, you know. So when you're outdoors and you're not very close to other people and it's a little windy, especially during periods that there is not a huge number of cases, then, you know, I feel safe with something like that. And I will have the mask when I'm not eating, and then I remove it, we eat, and that has worked fine. So I would say outdoors as much as possible.
Thank you very much, Professor. Going back to the CO2, sir, can you please comment on carbon dioxide as a surrogate indicator of how clean or coronavirus-laden the air is, particularly for 24/7 environments such as hospitals and offices with multiple shifts? The questioner is of the impression that recommendations are basically from studies of single work shift environments. For your information, Philippine TLV for CO2 is 5,000 parts per million. I will not pretend to have understood the whole question, sir, but maybe it's more familiar with you. Go ahead, sir.
I mean, the 5,000 parts per million is outside of the pandemic, and that's so you don't, because above 5,000 parts per million, you will start hurting your patients or whatever, because you get so dumb with so much CO2. But that's very unsafe in general. You know, you should never have more than 1,500 even. Now, it doesn't matter one shift or another shift, because really the virus, as we were saying the other day, is only going to last an hour in the air or something like that, because it's losing infectivity, is being, so really, you know, if you have 3 shifts of 8 hours, during the first hour, there is some CO2 and some virus maybe from the previous shift, but during most of the shift is the people you're with that matter, you know. So I would say, I mean, the limitation of CO2, you know, ideally we will have a machine that measures the virus, right? As you go to this and goes ping, ping, there's the virus. You can buy those, people will sell them to you. I don't know how well they work. They cost $30,000. You know, if we're saying that $100 CO2 meter is difficult, now how many $30,000 things we're gonna have? I haven't seen anyone, even in the US, which is a richer country, you know. So I mean, maybe they have one in the office of the president of the Philippines. That you know, that's the kind of thing, or the president of the big companies or something. But for most of us, CO2 is what we have to use, right? And then the only problem is it's not measuring the virus, you know. And many people are exhaling CO2, but they are not infected, you know. But it gives you the best indication of whether the air is being trapped or is being ventilated, you know. So that's what is useful.
Thank you very much for that, sir. So what I got from there is we have to also review our standards in terms of the work environment. And again, maybe we really hope that people are tuning in these particular places of influence and authority, and maybe can start moving that conversation forward. Thank you, Professor Jimenez. Copper masks, sir. Oh, go ahead, sir. Sorry. Go ahead, sir. Sure.
Medina, if I can say one more thing.
Go ahead, sir.
Actually, that you know, people may say, "Oh, we have a standard of 5,000, and this American is telling me to lower it to 1,000 outside of the pandemic." But you know, if you own a company and you have engineers or you have people doing tasks or you have whatever, they are a lot dumber at 5,000. I mean, there is many studies where people make much dumber decisions, much worse decisions. So why would you keep your people that you are paying them a salary and now they are doing stupid things because you have them in this toxic, this lethargic environment? And the same in a school. You know, people go to the university to learn, and you put them in a room where they are not learning very quickly because their brain is intoxicated with CO2, right? So there is huge benefits for society besides less transmission of COVID or other respiratory diseases from better ventilation.
So again, sir, that emphasis that we have to be thinking also long-term. These things have benefits even beyond the pandemic. Thank you very much, Professor Jimenez, for emphasizing that. Sir, this one's a bit controversial here in the country, at least. Have you heard of copper masks? They've become popular for a time here in the Philippines. And so what are your views on their effectiveness?
That's a waste of money. They were popular in other places, and the idea was at the beginning of the pandemic. Again, the idea with masks was that, you know, people may cough on your face and then the virus is there, and if you touch it, you're going to get infected then. But we know now that that's not that important. So then the idea with copper is that there were studies that show the virus survives less time in copper. But again, if the virus is in your mask, just, when you remove your mask, you wash your hands, doesn't matter to you. So why waste time on copper mask? And there is other types of masks that they sell, and they tell you, oh, it kills the virus or something. Don't waste your money on that. Get a good N95. That's what you need.
Thank you very much, Professor. Fit and filtration again, to the people who are listening. Um, Before I continue with the last maybe 6 questions, sir, that the team has curated and combined, there are things in the Q&A that are still unanswered. So we apologize if we didn't prioritize those, but now that we're towards the end of the combined questions, we just wanted to cover, sir, all of these questions and comments, and then we will go to the questions if we have time. So just to reassure the people who have upvoted that we are not ignoring your inputs, we're just trying to manage the time because we have limited time. Thank you again to everyone for understanding. Professor Jimenez, in terms of these respirators, you mentioned them in your talk. Is it advisable to wear the industrial 3M gas respirators, the ones with exhaust valves or similar equipment?
No, those are thought for something else. So let's imagine you are working with wood, or making holes, drilling concrete, and it makes a lot of dust. So the source is always on the outside, and you just don't want to breathe that dust into your lungs. Then having a valve is fine, because then when you inhale, the valve closes and is safe. When you exhale, the valve opens, and then you breathe more easily, right? That's the idea. Now, for this, since anybody can be infected, you shouldn't use the ones with valves. If it has a valve, you can close it. Like I showed, the one I use has a valve because by law it has to have a valve, but they send you a plug. So I just put the plug, and then it's like it didn't have a valve. So yeah.
Thank you very much for that, Professor Jimenez. This is a very common question also even from last time, sir. Finally, sir, are personal protective equipment like gowns for patients a waste of time and resources for dental visits or doctor visits? Would you say, sir?
For patients, yeah. I mean, maybe for the dentist, but not even. I think it's, everything costs money. And we have limited money, all of us, so use it on what's really important. So a good N95 mask, an eye protection, and anything else, and then wash your hands. And I said that's all there is to it.
Thank you very much for that, sir. Sir, for both public and private transportation, should we open all windows always? Would that be your recommendation?
If possible. I mean, it depends. In the subways, sometimes, I mean, it's better if you can open them. In the buses, sometimes you cannot open it, others you can. I mean, in general, if it's tolerable, if it doesn't get really hot or really cold, it's better to open it. In fact, sometimes people are very scared of the subway or of the metro, but then they go 4 or 5 people in a car with the windows closed without a mask. That's much more dangerous than the subway. So you have to be careful. If you share the car with other people that you don't live with, you should wear it's a very small room. It's a very small room with a very high occupancy, and you are all sharing the same air. As I showed, the CO2 accumulates very quickly. So you have to have the windows open or the ventilation system coming from the front, and wear a very good mask, because it's a risky situation.
Thank you very much. Go ahead, sir.
Talk less if you can. You put the radio or you listen to The Hills or some other song you like.
Yes, Professor Jimenez. Something that I need to remember, because I kind of talk a lot. My wife knows that. Anyway, since carbon dioxide, sir, gets through HEPA filters, or carbon dioxide monitoring is unable to gauge the effectiveness of air purifiers, will PM 2.5 concentration monitoring be useful, sir?
So that is correct, and that is one limitation of CO2. So what we say normally, if you don't have filters, try to keep it below 700 or 800. If you have filters, you can go maybe to 1,000, something like that, depending if the filters are big. Now, you can monitor with a PM monitor, but it's a little more specialized, because for CO2 is easy, because if you go indoors, in the large majority of situations, almost all the CO2 is from people. You can have some CO2 if you're cooking with gas, or you can have CO2 if you have a dog, but it's normally not very important. So it's mostly from people. Now, if you go indoors and you measure with a PM monitor, like that may cost $100 or $200, most of the PM is not from people. It's not these respiratory aerosols. Is aerosols from outdoors that come in, or from cooking, or from when you walk, we kind of resuspend aerosols. So, and basically when people try to measure what we exhale, you need to go to a clean room where there is basically no aerosols of any other kind. Only then you can see them, because there are very few. Now, there are very few, they're very potent because they have the virus, right? So then these monitors are useful if you want to test a filter. For example, you have a room and now you turn the filter on and you measure how the concentration goes down in time. That is how you tell that the HEPA filter is a real HEPA filter, and that the specification. So is with one of those monitors that costs, I guess you have some for $100 or $200, not only the $5,000 I was thinking about. So, but it's more specialized. I would say that's more for a scientist or an engineer. Otherwise, it can be confusing. You know, you have to practice, you have to learn, you have to read about it.
Thank you very much for that, Professor Jimenez. This might be this is interesting to me in particular, but maybe you can weigh in on this. Sir, what are the implications of the aerosol spread with regards to contact tracing? Considering that 1 meter per minute exposure might no longer be appropriate, sir. Would you still, what are your thoughts about the contact tracing process or changes to the contact tracing process, sir?
I mean,
Would you be able to, yeah, go ahead, sir.
Yeah, that's very important. And I mean, what I showed last week was in Hong Kong when they had the first 1,000 cases until they managed to control the first wave of the pandemic. Half of the cases they couldn't trace, even though they tried to do contact tracing, they couldn't find. I think a lot of those were infected in shared room air, but they didn't trace. They only traced people who were either in a cluster or they were talking close to each other. So I think, I mean, if you want to be rigorous, then you have to contact trace people who were in the room for a long time. But then what happens when you have a lot of cases, that becomes, then there's too many people to contact trace. So I would say you should use a risk calculator like ours to say, okay, of the people who share the room, which ones should I contact trace? So for example, if someone was infected in a choir, I would contact trace everybody. If someone was infected in a library, I would only contact trace whoever they talked close, and that kind of thing. If someone was infected and they spend a week with other people or whatever, without a mask, definitely it was sharing the room. If they were for a short time and they were wearing a mask, then it's, you know, to prioritize your resources. So.
Thank you, sir, for that. Sir, how much risk is there in theaters or cinemas? Are they considered well ventilated in your experience?
It depends. I mean, it varies a lot. It's like buses. There are some that are well ventilated and some very poorly, you know. Now, cinemas, movie theaters, I haven't heard of any outbreak in a movie theater. And normally, I mean, what I would say, though, don't go to a funny movie, because in the funny movie, people are going to laugh. And when we laugh, we produce more aerosols. Go to more serious movies. People may cry, that's fine, you know. A theater, you know, the people who are talking are the actors and are not wearing a mask. So if I was in a theater, I would go very far. I will take a cheap seat far away from the scenario, from where people are acting. And I would say and you want to have as good ventilation as possible around the actors, but it varies a lot. And again, you have to, like, there is some colleagues in Mexico City and they were measuring in a theater, and it was very high. It was 3,000 or 4,000. And they said in this particular theater, it was very old and it was difficult. And then other colleagues were measuring in a movie theater and it was also high, but then other colleagues went to a different movie theater. It was very good. It was very well ventilated. And as I said, it's not always the more expensive one or the shinier place that's better. It can be very surprising. That's why there is nothing like measurements.
Thank you very much, Professor. Professor, this is a bit of a technical question, I think, or in my uninformed opinion as someone who's not involved in these things. Sir, how can you estimate the ACH when using ventilation, natural and or mechanical, and filtration? For example, one wants to target 6 ACH in the office. Can you also compute maximum occupancy in an area if one is targeting 700 parts per million? i.e. ventilation without filtration, perhaps as an average or standard of space per person. I hope I was able to read that, sir, very well so that you can answer.
I mean, I think that there are two ways. I mean, the problem with ventilation, I mean, you can always hire a ventilation company and they have more sophisticated ways, but that costs, I mean, hundreds of dollars or thousands of dollars here, you know? So then in terms of things that you can do, I would say there is two things, and they both involve a CO2 monitor. One is, let's say you're in a classroom and you have, I mean, 20 students and whatever, and you measure the CO2, and you know, at the beginning when you come in, it increases, but then it stays flat, right? Now you look at that flat level, and with our calculator, you can now calculate a classroom, and you can change the ventilation number until your CO2 matches what you measure. So that's one way, and then you can get the ventilation number. That's, hopefully that was somewhat clear. There is another way, which is that you can, in a room, you can increase the CO2 by people being there, or sometimes with dry ice, which is basically frozen CO2. You put it on water, you melt it, so you increase CO2 a lot, and then you leave, and you leave the CO2 meter. And then you record the concentrations, and then the time in which it goes down 63% of the original concentration, that's your ventilation rate. You know, so if it takes an hour, you have 1 per hour. If it takes half an hour, then you have 2 air changes per hour. I've written a post, I can find it. I've written a post that explains this second method. Again, it's something, I mean, my wife is an artist and she has done it. So it's not, I mean, she's smart, but this is very foreign to her, and yet she was able to do it. So, you know, it's definitely possible.
Thank you, Professor. Would love to be working collaboratively with these people who understood everything that you said for example, rural clinics or primary care settings, at least in my field. So for the people who are listening, please start collaborating. I think that's one of the key messages also of this webinar. Professor Jimenez, another question in terms of our dental colleagues. In what situations would it also be safe to go to the dentist as a possible patient? What questions, okay, maybe what questions can I ask the dental clinic to check if they are ventilating properly or reducing the risk for patients to get COVID? Maybe this can be extrapolated, sir, in many different settings. As the public, what can we ask or check so that we can say that this establishment or this clinic is really taking care of its ventilation? Go ahead, sir.
I mean, again, if in periods in which cases are high, that's definitely, I mean, I've gone to the dentist, as I said, but I've tried to go when cases were lower and avoid. Now that Omicron is high here, I'm not going, right? But then if you call them, you can say, okay, are you wearing a 95 mask? Is everybody wearing a 95 mask? Do you have either good ventilation or do you have filters? You know, and do you measure CO2? Many places don't, but you may find some that do. And or sometimes they don't know what you're talking about, but you can ask, would you let me open the windows and use a CO2 monitor and I can teach you how to do it? And some people will be offended, but some people, I mean, in many different countries, people report that the dentists are maybe very curious. It's like, oh, I can do this, and you can buy the thing, and you know, so you may have to call a few places, but you may find some are better than others. I mean, there is some people, like we were talking earlier, that don't want to have anything to do with, don't want to make any effort, and they will think you're crazy. Well, that's fine, you know. But you may find some people that do it more safely.
Thank you very much, Professor. And the last of the combined questions before we go to the Q&A, again, betraying what Filipinos enjoy. Professor Jimenez, Korean grill restaurants have been very popular in the Philippines. Are those with the exhaust systems for their grills, the suction for the smoke of the grill, safe for indoor dining? Can those be considered as good ventilation systems, sir?
They can be if they have this. Yeah, no, I like the Korean barbecue too. If they have this big exhaust and it's on, and they have some window open or something for the air to come in, then that can be a lot safer. But you don't really know until you measure the CO2. You know, if they have a good exhaust system, any exhaust from from the cooking should go there, and then the exhaust from the people should go there. So that may be safer, but again, I wouldn't trust it if I didn't go and measure the CO2.
Okay, thank you, sir. Again, that message of do these measurements as often as we can. Okay, thank you very much, Professor Jimenez. Thank you very much, Professor Jimenez, for saying that you can stay a bit more so that we still have time for these other questions. So we'll try to go through the most popular ones. This is the top voted question, sir. I think you answered this partially last webinar, but I'll just ask it again. Apart from airborne transmission, Professor Jimenez, can COVID-19 spread through medical and food waste cross-contamination? Relevant example was what was mentioned last week, the disposed swabs from RT-PCR and PPEs being disposed in the same dump truck, and landfills, sir, where unfortunately people who scavengers have to eat food scrap. So what would you be able to give your thoughts on that, sir?
Not easily. I mean, I would say food scraps. I mean, if you have someone with COVID who has bitten a chunk of pizza and some of their saliva is there, and then someone else eats the rest of the pizza, it is possible. And also like needles or things that have been in contact with COVID virus, it's possible. I mean, when I say that surface transmission is unlikely, is, you know, if you touch a light switch or you touch a table or something, and you know that's difficult. If you really go to these higher risk situations, it is possible. I don't think it's still very likely, but I would try to use alcohol or do something. Try to remember not to touch my face, and if you can, yeah.
Thank you very much for that, Professor. A related question, and again with a lot of upvotes, sir. Sorry. Does the virus, sir, live in water? For example, and again, a very practical, real scenario, when someone coughs and the virus lands on your forehead, and after washing your face with just water, the water drips around your eyes and lips, would you say people can be infected in that scenario?
I mean, I think it's unlikely. I mean, it's not water. I mean, by the, if you get the virus and someone kind of coughs on you and you have the virus here, it's kind of on a surface and it's going to lose infectivity relatively quickly. Now, if that has happened to you or something, and then and you touch your face, I will wash my hands. If you wash your face, I don't know, like try to wash it so that the water. I don't know. I mean, I don't think it's very risky. I mean, if you are like, if you work in a hospital and someone cough on your face and you have some of the cough here, I mean, maybe then you could take some alcohol and just put it on your forehead or something like that. I don't know. I mean, that would be the one situation where a face shield makes sense in a hospital. If people are coughing on your face, then if I work in a hospital like that, I would probably wear it too, but on top of the goggles,
Thank you very much for that, Professor. What about pets, sir? Dogs, cats? Are there already studies, sir? Go ahead, sir. Sure, sir.
Yeah. This virus seems to infect a lot of animals. It depends on the variant, but it seems that there are cases of cats and dogs that are infected, and deer, and there was a zoo where a lot of animals were infected. So now, and some of them can give it back to people. I don't know exactly with cats and dogs how likely that is, but it is possible. So you should be careful, I guess. I imagine you could do a test like one of these antigen tests with them. I don't know, but yeah, there are people. This goes a little bit beyond what I know. I'm sure you can find veterinarians that know more than me.
Thank you very much for that, Professor Jimenez. Professor, this might be a bit, I am interested here to pick your brain regarding this. Thank you for your talk and for highlighting or reinforcing the need for interdisciplinary approach in addressing this very complex challenge. Sir, if you will be tasked to lead the COVID-19 response for a local government unit or maybe even national, what would be your top 3 to 5 priority recommendations to manage the situation effectively? The pandemic, I suppose.
I mean, I think it's the things I mentioned. Explain it. Give the smoke analogy. Some infected people, not everybody, many infected people don't infect anyone, but some are exhaling during a short period, a lot of invisible smoke, and we get infected by breathing it. That's the main way. We want to avoid that. So think wherever you are, in a car, in the bus, at work, in the mall, with your family, that's what you want to avoid. And then tell people, go outdoors. If you go indoors, be careful and wear a good mask. I mean, those would be the top things, and ventilate, and try to ventilate the best you can. Those would be my top things.
Thank you very much for that answer, sir. To the team, to the moderating team, can you please help me dismiss or Mark has answered the things that we've already addressed earlier. But then just a reminder to the audience, yes, Professor Jimenez just confirming again, but we asked you this before, you can be quoted, right? And your slides and photos can be used to communicate the science here in the Philippines.
Yeah. Well, you can use the video, you can use the slides, you can do whatever is useful. And
Thank you very much for that, sir. Go ahead, sir. Sorry.
Yeah, I know sometimes I get myself in trouble being too critical of governments or whatever, but I say what I think, and you can use whatever is useful.
Thank you very much, Professor. Again, a reminder that we should also contextualize these things. So, but thank you very much, Professor, for that. Sir, this one, can windows be opened if you live in an apartment or condominium or townhouse with an infected neighbor nearby? It's a very practical question. So would you be able to answer? Go ahead, sir.
Yeah, it's a good question. I mean, and there are cases of transmission within apartment buildings. There are some that have been investigated in Korea and in China. And I know some colleagues are investigating some in Spain. So this can happen. Just like sometimes someone is smoking in a different apartment and you smell it, or someone is cooking in a different apartment and you smell it. That's because you are getting the air from the other apartment. So that's the kind of situation where you want to be more careful. So, you have to think about your situation. In some cases, there are apartment buildings that there is like an air shaft, a patio that they share, and then there is windows on the street. It's better to open the ones on the street, because those are going to have less common air than in the air shaft. Sometimes there is, in some buildings, there is conduits that communicate all the bathrooms. And that can be dangerous in some cases because the air can come out of one bathroom and into the next one, And sometimes you have an exhaust and you're running the exhaust in the bathroom, like a fan exhaust or in the kitchen. And that actually is bringing air from other apartments if you haven't opened a window. So you have to think about it. Again, it's kind of confusing, but you can think, okay, is the air coming below the door? Light a match and see if the air is coming below the door, or use some way, with a little piece of paper, see if you can see where the air is going, that kind of thing. And I don't think it's not as high risk as talking to someone or being in the same room at the same time, but there is some risk and there is cases of infection.
Thank you very much for that, Professor Jimenez. Professor, for the Corsi-Rosenthal box, what's the airflow direction? From fan to the filters, or air goes to the filters and then exhaust by the fan?
I believe
yeah,
it's
go ahead, sir.
From the fan to the filter, that works better.
But there's a comment here, by looking at it, it may have leaks. What's your stand on it in making sure the collected dust with the virus does not spread back to the environment?
I mean, what you do is that you tape it, so you tape all the gaps, and you can do that pretty well. And people test this with one of those particle meters that we were talking about earlier, and they work pretty well. Now, the collected virus, if you run it that way, the fan to the filter is on the inside of the filter. So even you touch the outside of the filter, you are not touching the virus. And the virus, the aerosols are going to stick very well to the filters. It's very unlikely that they're going to come back. So I think it's, yeah, and in any case, it's much better, even if they only remove 99% or something, it's much better to leave 1% than to leave 100%, so anything that removes aerosols from the air is going to help,
Thank you very much, Professor. Maybe a related question to what was asked earlier. As a scientist, sir, how do you communicate to government? In your experience, how has it been communicating to governments? And maybe if you can give us tips as to maybe a bit more practical, I suppose, from the person who
I mean,
asked the question. Go ahead, sir.
it depends if the government is open-minded. Okay, so yeah, I've talked to many governments of many countries, national, regional. Some governments are open to listening, so they really want to do things better. And so I talked to people who talked to the president of Argentina, and they convinced the president to do a campaign about ventilation, and they convinced the governor of Buenos Aires to buy 30,000 CO2 meters for all the schools. And I talked to someone in Belgium that I was mentioning last week that is like an independent commissioner, and he can have rules, and he mandated CO2 meters and things. Now, I've also talked with a lot of other governments who don't want to do anything because for different reasons, for the reasons we mentioned earlier. And then they will look for excuses, and they say, but you say this, but this other scientist says something else. So then, in a way, they are talking to you so they can defend themselves better if they are. So they know people like us say. So we're almost like a free training session, but they don't really intend to do anything. And there are let's say, and there are others. I mean, I had some cases. I talked to a government, and they were very excited, and I was telling them about the CO2 meters and whatever. And then 1 hour after we talked to them, they put an announcement, a press release, saying they were going to buy a CO2 meter for every classroom, and they were going to buy 30,000 CO2 meters. And it was on the press. It was reported everywhere. And the only problem is they never bought them. They only did the press release. So all they wanted to know were things they could say, to score political points, because there was an election coming. But then the election happened and they didn't do anything, So it depends. I mean, I think you have to try. We all have to try to help the governments. I mean, understand that they are very busy. You have to simplify things. They want the evidence. They want the articles. They want to make sure people saying it are reputable and all that. But then not all of them are open to listen.
Thank you very much for that, Professor. I hope that in our country, the local interagency task forces and the national interagency task force at least have something to really discuss and debate on at the very least, and maybe we can move these conversations and action points forward. Sir, I was looking at the Q&A, and maybe this was also addressed earlier a bit, but I think this is a valid, again, question from people who know these things better than I do. Sir, the full question and comment is, and you partially answered this, why focus on CO2 level and not on the more direct ventilation rate indicators like air exchange rate through inflow of fresh air and outflow of used air to maximize the dilution and then evacuation of air in enclosed spaces? If the inflow is from a polluted source, like a road with congested traffic, the CO2 level of the adjacent enclosed space may increase, and this increase cannot be taken as a COVID-related parameter. You were starting to explain that, sir, earlier, but maybe just a bit more, sir. Yes,
I mean,
go ahead, sir.
really, when we say, I mean, CO2 outdoors is about 400 parts per million. So when we say, like the CDC says 800, really what they're saying is whatever is outside plus 400. If you are in New York City or maybe in Manila in the busy sections, maybe outside is 500 or 600. So that's the 400 that's everywhere plus 200 from the traffic. And then you add 400 on top of that, right? So it's just a little more complicated. Now, why do we promote CO2 and not air changes per hour or something? I mean, at the end, what matters is the air changes per hour and that, but or is also important, but that's very confusing. I mean, you can do the experiment that I put, and that's what I was telling people at the beginning, but then I realized nobody understood, and it was much easier to tell them to measure the CO2, and it's something that everyone can learn. Everyone who's interested, even if they're the teacher of philosophy or someone who's never measured anything, has anything to do with science, they can learn if they pay attention, and it's not very complicated. To quantify air changes per hour is just, I mean, it's great if you can do it, but it's just more difficult, much more difficult.
Thank you very much for that, Professor. And maybe just to be fair, there's a reaction here that I think is important also. I believe there's a department order, if I'm reading this correctly, 224-21 on ventilation issued by the Department of Labor and Employment set the CO2 parameters to 1,000 parts per million. So somehow, sir, that's better than what it used to before. So maybe just to be fair, I think the audience really needs to search out these things. And again, those local interagency task forces have to start talking about these things more among themselves. So thank you very much for that comment, sir. Okay, I'm running through the questions. Professor Jimenez, you might are also looking at the Q&A. Like last week, I don't want to miss something that you really want to answer. But it's already 10:07 here in the Philippines. I think it would be nice if we can wrap up. Oh, sorry, there's somebody here who prompted me, sir. Sir, in terms of the practices, we have local practices like steaming. We call it suob here, where we inhale the vapor, sir, of heated liquids so that they can offer symptomatic relief. What can that do, sir, to the virus or the probability of the virus in the air, especially that is very common, sir, in the provinces? Go ahead.
I mean, I think you mean if you are infected and are doing that, or you may share the air with someone infected that's doing that.
Yes, sir. I'm not sure, sir.
Or
yes,
either way.
Either way, sir. Yes, sir.
I mean, if it's hot, the heat tends to deactivate the virus faster. I mean, the like anything in biology or with food, the cold conserves the virus, the heat destroys it faster. If it's very humid, that also can help the virus. Now, if there is some eucalyptus or some smelly thing in the air, some of those can be disinfectant. So it depends. I mean, overall, I wouldn't say it's very important. I would say it's similar as in other places.
So there have been medical issuances regarding the dangers and benefits of these things, Professor. So hopefully the people can put those together, and the ones who can communicate these things better will do so. So thank you very much for that. Sir, one last, in the Philippines, since we are a very disaster-prone country, we might have to talk about this early, or actually belatedly. In terms of evacuation centers, sir, in terms of the adjustments, would you know of any evidence regarding infections or transmissions in evacuation centers because of natural disasters? Or again, the principles in my head, they do apply, but if you can comment about them, sir, in disaster situations. Go ahead, sir.
Yeah, so there are cases in which, for example, there was a hurricane or yes, there a typhoon or whatever, and then if people end up being indoors in a place that may not be well ventilated with a lot of people, that's a situation that's favorable to transmission. So, if there was a typhoon that was coming next week, I would say make sure in the evacuation centers that you have good masks, and as people come in, you give them a good mask and try to encourage them to wear it the whole time and ventilate as much as you can. But it's definitely, I mean, depends, of course, right? If you can, sometimes an evacuation center is a stadium and it's huge and there is a lot of dilution. Sometimes it's some place that's smaller and there's, so it depends, but there definitely can be transmission in those situations.
Thank you very much for that, sir. And okay, it's 10:10. Professor, we don't want to keep you beyond the 15 minutes that you so graciously offered to us. And again, we are very sorry if we have reached the end of our open forum, but it has been a very animated Q&A with Professor Jimenez. If you do have any further questions, you can send your questions or to our official Discord group chat, and we will try our best to answer questions. And then for those that we unfortunately weren't able to make time for during this webinar, we'll forward them again to Professor Jimenez, and maybe if he can answer some of the questions, we'll try our best also to communicate these to our participants. Professor Jimenez, go ahead.
Medina, I can do one more thing. If there are questions that I haven't answered and maybe the organizers could select 10 or 20, I could then respond to them on Twitter and then send you the link, and then people can read the answers there.
Okay. One last question, sir. Let's insert this. For the air purifiers, in the QA box, I read somewhere that UV lights located inside the component part of air purifiers are not that useful because the time that the air is exposed to the said UV light is not significant enough to kill the virus. Can you comment, sir, on the accuracy of this?
It depends on the device. It depends on, how much air is going, at which speed, how much light is there. Often in the things that are very cheap, it tends to be the case. I think it can be done so that it works, but then it tends to be more expensive. But in general, UV is more expensive than filters for the same efficacy. So I would say for a classroom, for a shop, for most places, go with filters. It's just going to be simpler, cheaper, and safer.
Thank you very much for that, Professor. And Professor, any final words before we do formally close the webinar, sir?
Thank you for listening. I hope it has been useful. And as I said, if you compile more questions, I can answer them in Twitter. And I hope, it's this does. I mean, this type of thing can help provide some pointers, but then a lot of the work is for you and for the government in putting it in practice in your local context. I mean, I think the message is there is a lot we can do that we haven't done very well. And if we do it, we can reduce transmission a lot. So there is low-hanging fruit. It's not like we are already doing everything so well and we're talking about the 1%. No. We've been doing things. I mean, I don't know about the Philippines, but certainly in the US, we've been doing things very poorly. So there is a lot that we could improve if we paid attention.
And thank you very much for that, Professor. And thank you once again. And before we formally end the session, just a bit of webinar housekeeping. Certificates of attendance will be given after attending both sessions of the webinar. So we might not be able to give everybody a copy of their certificates. You have to have been in part 1, but definitely the recordings and the proceedings will be disseminated as widely as we can, given what Professor Jimenez has shared. And so we request everyone to accomplish the evaluation form of the session so that we can issue you your certificate. The link to the evaluation form can be accessed through the chat box. And please give us time to prepare the certificate. We have more than 1,000 participants, I think, that have joined the webinars, and more than 3,000 who have registered. So we will be issuing the certificates by the first week of March. We would also like to extend our appreciation and gratitude again to Professor Jimenez for his insightful, very timely, and very relevant webinar. To our participants, show your appreciation using the reaction buttons. I think they're disabled for the Zoom webinar, but you can please show our appreciation for our speaker in many other avenues on social media in particular. And we would also like to thank our partner institutions and organizers who made this webinar possible. The UP Open University, the UP Diliman College of Science, the UP Diliman College of Engineering, the UP Diliman Institute of Civil Engineering, the UP Los Baños Graduate School, the UP Manila College of Medicine, the UP Manila Community Health and Development Program, the UP Manila College of Nursing, the UP Baguio Office of the Vice Chancellor for Academic Affairs, the UP Diliman Office of the Vice Chancellor for Academic Affairs, and the UP Los Baños Office of the Vice Chancellor for Academic Affairs. And that ends hashtag COVID is Airborne, Understanding and Implementing the Paradigm Shift webinar. This has been a privilege. I am Dr. Paolo Victor Medina, and thank you for joining us. See you, God bless, and stay safe, everyone.